The thoracic duct is the largest lymphatic vessel in the body, responsible for draining lymph from most of the body into the venous system. It is essential for fluid balance and immune function and plays a key role in returning lymph, lipids, and immune cells to circulation. In this video, we will explore its anatomy, function, and clinical significance. To do so, we will start with a brief introduction. Its descriptive anatomy, followed by its anatomical relations, its collateral branches, the anatomical variations of the thoracic duct, some key clinical notes and applications, and finally a conclusion in order to summarize all the key points. The thoracic duct is the body's main lymphatic collector. It drains all the lymph from the subdiaphragmatic region and the lymph from the left half of the supradiaphragmatic region. Let's start with the descriptive anatomy of the thoracic duct. The thoracic duct originates from the confluence of two lumbar lymphatic collecting trunks and the intestinal trunk. Its origin might be variable. Sometimes it is high, intrathoracic, located just anterior to T11 or T12. Sometimes it is low, intra-abdominal, just anterior to L1 or L2. In this case, its origin is often dilated, forming a variably shaped enlargement, sometimes ampullary, known as the cisterna chyli. In its thoracic segment, the thoracic duct ascends almost vertically in the posterior mediastinum, with a slightly oblique upward leftward course, particularly at the level of T4 and T5. In its cervical segment, after passing through the superior thoracic aperture, it follows a concave curve downward, forward, and to the left. The thoracic duct drains into the left jugulosubclavian confluence or one of its two contributing veins. The abdominal segment is deep, prevertebral, and retroaortic. The thoracic segment, which is the longest, is located far posteriorly in the posterior mediastinum. And its cervical segment is positioned in the lower and inner part of the left omoclavicular triangle or left supraclavicular fossa. Concerning its external configuration, the thoracic duct appears as a long, grayish-white conduit, with a consistency roughly similar to that of a vein. Internally, it contains valves, though few in number, which prevent lymph and chyle reflux, particularly near its extremities. Its length is approximately 30 centimeters. Its caliber remains fairly constant along its course, measuring between 2 to 3 millimeters. Except for dilatations at both extremities, the cisterna chyli at its origin, and the thoracic duct ampulla at its termination. Let's tackle the anatomical relations of the thoracic duct, starting with its abdominal segment. This segment is inconstant, prevertebral, and retroaortic. On its diaphragmatic passage, the thoracic duct is positioned behind the right border of the aorta within the aortic hiatus of the diaphragm, sharing its anatomical relations. This longest segment of the thoracic duct is the thoracic segment, and it's entirely within the posterior mediastinum and can be subdivided into three portions. The subazygous aortic segment, below the azygous vein and aorta. The interazygous aortic segment, between the azygous vein and aorta. And the supraazygous aortic segment, above the azygous vein and aorta. The anatomical relations of the subazygous aortic segment are the following. Posteriorly, the right posterior intercostal arteries. The hemiazygous veins, which cross transversely to drain into the azygous vein. Further back, the vertebral column from T12 to T5, covered by the anterior longitudinal ligament. Anteriorly, the aorta and the esophagus. Laterally, the azygous vein on the right, which receives the right posterior intercostal veins. And on the left, the descending thoracic aorta, giving off posterior intercostal arteries. The anatomical relations of the interazygous aortic segment are: posteriorly, the fourth thoracic vertebra. Anteriorly, the esophagus, which it crosses from right to left along the posterior surface. And the right bronchial artery. Laterally, the azygous vein arch, at some distance. And the aortic arch, to the left. In the supraazygous aortic segment, the thoracic duct runs along the posteromedial surface of the left subclavian artery, sharing its anatomical relationships. Posteriorly, the second and third thoracic vertebrae. Anteriorly and to the left subclavian artery, covered by the pleura. To the right, the esophagus, being its main relationship. The trachea. And the left recurrent laryngeal nerve. The thoracic duct also crosses the superior thoracic aperture, which is bounded by. Posteriorly, the second thoracic vertebra. Anteriorly, the jugular notch of the sternum. And laterally, the first rib. It occupies a very posterior and left paramedian position, with the following relationships. Anteriorly, the esophagus on the right. And the left subclavian artery on the left. And the trachea and the pretracheal vasculonervous structures, located more anteriorly. Laterally, the left pleural dome, with. Posteriorly, the supra- and retropleural recess, close to the thoracic duct. And anteriorly, the lower part of the omoclavicular triangle. At its cervical segment in the left base of the neck, the thoracic duct curves, forming an arch at the level of C7. Above the left pleural dome, and 3 to 4 centimeters above the clavicle. The arch of the thoracic duct corresponds to. Anteriorly, the left common carotid artery. The left internal jugular vein. And the left vagus nerve. Posteriorly, the left vertebral artery and vein. The left sympathetic trunk. And the left cervicothoracic ganglion. Laterally, it corresponds to the left phrenic nerve. The left thyrocervical trunk. The left anterior scalene muscle. Medially, its relationships are the esophagus. And the longus colli muscle. Let's delve into the collateral branches and collateral pathways of the thoracic duct. The thoracic duct receives numerous collateral lymphatic vessels. The phrenic lymphatics. The thoracic lymphatics, that give intercostal and posterior mediastinal pathways. And the cervical lymphatics, which include the jugular trunk, draining the left half of the head and neck. The subclavian trunk, draining the left upper limb. And the bronchomediastinal trunk, draining the heart, lungs, and the left half of the thoracic wall. For the collateral or accessory pathways, they are of two types, accessory lymphatic pathways and lymphovenous anastomoses. The accessory lymphatic pathways are normally thin, and become significant when the thoracic duct is damaged. They include the paraesophageal pathways, draining into the left bronchopulmonary lymph nodes, then into the left jugulosubclavian confluence. The transdiaphragmatic pathways, perforating lymphatic trunks. The paracaval pathways, draining into the right jugulosubclavian confluence. And the paraumbilical pathway. The lymphovenous anastomoses are present in 50% of cases, and can occur at various levels: lumbar, renal, mesenteric, azygous, and inferior vena cava veins. Let's discuss now the different anatomical variations of the thoracic duct. There are numerous variations which can affect either its origin, by being high or of thoracic origin, or low, or of abdominal origin, with the cisterna chyli being inconsistent. It could also affect its course and pathway, where we can describe an inverted duct, double duct, or multiple ducts, especially in the lower or middle portions of the path. At the termination of the thoracic duct, it's possible to find multiple arches, including bilateral arches, right-sided arches, etc. Finally, we'll turn our attention to some key clinical applications. By detailing the rupture of the thoracic duct. Due to the thinness of its wall and its almost colorless appearance, the thoracic duct can be difficult to recognize. Therefore, it is vulnerable and may be accidentally injured during certain investigations or surgical maneuvers in the posterior mediastinum. A rupture occurring during an accident or surgery on the lung allows lymph to escape into the thoracic cavity at a rate of 75 to 200 milliliters per hour. The lymph can also enter the pleural cavity and cause chylothorax. The spilled fluid can be removed using a cannula or by thoracocentesis, but in some cases, it may be necessary to ligate the thoracic duct. The lymph then joins the venous circulation through collectors that drain into the thoracic duct above the ligature. To conclude, the anatomical study of the thoracic duct is important due to the multiplicity of anatomical variations and the frequency of its pathology.